Welcome to the deep dive. Today, we're really going to get into the thick of it with chemotherapy pharmacology. We're focusing on chapter 53 from Lilley's, specifically the cell cycle nonspecific and, well, the miscellaneous antineoplastic drugs. Our goal here is to quickly map out the essentials, how these drugs work, what makes them so dangerous, and the key safety points you absolutely have to know. These are the heavy hitters, the ones that attack cancer cells no matter their phase in the cell cycle. And because of that, the clinical stakes are incredibly high. We need to nail down the classes, the DNA attack methods, and especially the organ damage risks.
Exactly. It's really about understanding the risks to prevent harm. So we'll cover the two big cell cycle nonspecific classes, alkylating drugs and cytotoxic antibiotics. Then we'll touch on the hormonal and miscellaneous agents. The key is seeing how they damage DNA, because that helps predict the toxicities that demand, well, really sharp nursing care.
Okay, let's jump in. And we're starting with a class that has kind of a dark origin story, right? Developed from chemical warfare agents.
That's right. The first major group, the alkylating drugs, actually came from mustard gas research during World War I. That's where drugs like mechlorethamine, which you might know as nitrogen mustard, got their start. It's quite the history.
Fascinating. But clinically, what matters is the action. What exactly is alkylation doing?
Well, think of it as DNA sabotage, really. The drug transfers these chemical bits called alkyl groups onto the cancer cell's DNA. This messes things up by forming abnormal chemical bonds or cross-links between the two DNA strands.
Like welding the DNA strands together so they can't separate.
Exactly like that. It prevents the DNA from unzipping, which it needs to do to replicate. So the cell ends up with defective DNA, it can't divide properly, and essentially it leads to cell death.
Okay. And I see terms like bifunctional and polyfunctional. What's the difference there?
It's about how many places the drug can attack. Bifunctional means it alkylates at two sites on the DNA. Polyfunctional means it can jump into several alkylation reactions. A really common example is cyclophosphamide. It's a prodrug, meaning it gets activated in the body, and it's polyfunctional, making it very effective.
So in Canada, the main alkylators we'd see are cyclophosphamide, maybe carmastine, and the platinum drugs like cisplatin.
Those are key examples, yeah. Cyclophosphamide is classic, carmastine is a nitrosourea, and cisplatin is technically a miscellaneous alkylator. But they all work through that DNA damage mechanism.
Right. And as soon as you see one of these ordered, the alarm bells for side effects should be ringing loud and clear. The big general one is myelosuppression, right? Bone marrow suppression.
Absolutely. That's the dose-limiting toxicity for many dangerously low blood counts, which means a huge risk for infection. That's sort of the baseline worry.
But then there are the specific organ toxicities, the ones you have to anticipate and actively manage. Well, let's hit those critical ones for the alkylators, maybe referencing table 53.1 in Lilley's.
Okay, three big ones. First, the platinums. Cisplatin is, well, notorious for nephrotoxicity, serious kidney damage. Plus, it can cause hearing loss, ototoxicity, and peripheral neuropathy. Managing that kidney risk means aggressive IV hydration is non-negotiable.
How much hydration are we talking?
Usually 2,000 to 3,000 milliliters per day. Unless there's a cardiac reason not to, you have to flush those kidneys. And like you hinted, you cannot pile on other kidney-damaging drugs like amiglycoside antibiotics with cisplatin. That's asking for renal failure.
Okay, kidney damage with cisplatin. What's number two?
The bladder. Cyclophosphamide specifically can cause hemorrhagic cystitis. That's bleeding and irritation of the bladder lining. And again, the main countermeasure is hydration, hydration, hydration to flush out those toxic metabolites.
And the third specific target?
The lungs. With busulfan, you need to be vigilant for signs of pulmonary fibrosis, a serious lung scarring.
Okay, this brings us to something critical for anyone giving these IV meds, extravasation. The absolute nightmare scenario.
It really is. Extravasation means the drug, especially if it's a vesicant something that causes blistering leaks out of the vein into the surrounding tissue. And because these drugs are so chemically aggressive, it can cause horrific tissue damage, necrosis, even potential loss of the limb. It's an emergency.
So immediate action is required. Central lines are preferred to avoid it, but if it happens, say with carmastine, like table 53.2 mentions.
Right. The protocol for carmastine extravasation is specific. You'd stop the infusion, leave the cannula in briefly, and try to aspirate any residual drug. Then inject a mix of sodium bicarbonate and normal saline into the area, followed by applying cold compresses. Recognizing it early and acting fast is everything.
Okay, so alkylators chemically cross-link DNA. Let's shift to the next big cell cycle nonspecific class. The cytotoxic antibiotics. These come from mold, streptomyces. How do they kill cancer cells? Different mechanism.
Totally different approach. Instead of chemical bonds, they use a physical mechanism called intercalation.
Intercalation.
Yeah.
Sounds like inserting something.
That's exactly it. The drug molecule literally slips itself in between the base pairs of the DNA double helix, like sticking a bookmark into a book. This physical block jams up the enzymes needed for DNA synthesis. Plus, they often inhibit an enzyme called topoisomerase II and generate free radicals, which cause DNA strands to break. Double trouble for the DNA.
Myelosuppression is common here too, I assume.
Generally, yes. But again, the crucial exceptions, the ones that really guide clinical practice, involve specific organ damage, lungs and heart.
Let's start with the lungs again. Which drug is the main culprit here?
That would be bleomycin. Similar to busulfan and the alkylator class, bleomycin is known for pulmonary toxicity, pneumonitis, fibrosis. This often means there's a lifetime cumulative dose limit for patients and requires careful respiratory monitoring.
Okay, lungs with bleomycin. And the other big one is the heart, right? Especially with the anthracyclines.
Yes, drugs like doxorubicin and doxorubicin. Highly effective, but they carry this major risk of cardiotoxicity.
That sounds serious. Dose-related heart failure.
It is serious. Anthracyclines can cause cardiomyopathy, and the risk is directly tied to the total cumulative dose of, say, doxorubicin a patient receives over their entire lifetime.
Wow. So how do you manage that proactively? You can't just wait for heart failure symptoms.
No, absolutely not. Management involves regular monitoring of the heart's pumping function, the ejection fraction, usually with MUGA scans or echocardiograms before doses are given. Physicians have to track that cumulative lifetime dose very carefully, and sometimes a cardioprotective drug called dexrazoxane might be used alongside it. It's a constant risk-benefit calculation.
And what about extravasation with doxorubicin? Same protocol as carmustine. Box 53.1 mentions it.
No, it's different, which highlights why you need to know the specific protocols. If doxorubicin leaks, you stop the infusion, try to aspirate. But then management typically involves cooling the site for 24 hours and elevating the limb. The goal is different, localize and cool versus neutralize.
Interesting. And I read doxorubicin also comes in a special formulation, a liposomal delivery system.
That's right, like Calyx or Myoset. The drug is encased in a tiny lipid bubble. This does a couple of things. It dramatically increases the drug's half-life in the body. We're talking 50, 60 hours. And importantly, it tends to reduce some of the systemic toxicities, potentially including some of the acute cardiotoxicity, by changing how the drug distributes in the body.
Good to know. And a quick interaction note. Bleomycin and doxorubicin can apparently increase digoxin levels.
Yes, that's a key one. If your patient is on digoxin for heart issues, adding one of these could push their digoxin levels into the toxic range. So you need careful monitoring there.
Okay, let's pivot now. We've covered the non-specific DNA attackers. What about the miscellaneous and targeted agents? These sound more specific.
They often are. This is a category for drugs with unique structures or mechanisms. A major one is bevacizumab. It's a targeted therapy, but it doesn't target the cancer cell itself.
It targets the tumor support system, its blood supply.
Exactly. Bevacizumab is an angiogenesis inhibitor. It binds to a protein called vascular endothelial growth factor, or VEGF. BCF is what tumors use to signal for new blood vessels to grow angiogenesis. Bevacizumab blocks that signal, basically starving the tumor by cutting off its supply lines.
Blocking blood vessel growth systemically sounds like it could have widespread effects. What are the adverse effects?
You're right, it can cause systemic issues. Things like hypertension, sometimes hypotension, risk of blood clots, DVT, potential for GI bleeding or even perforation, and kidney problems, specifically proteinuria.
Another really important targeted drug is imatinib mesylate. That's changed the game for CML, chronic myeloid leukemia, hasn't it?
Absolutely. Imatinib is often the standard of care. It's a prime example of targeted therapy. CML is driven by a specific faulty enzyme, the BCL tyrosine kinase. Imatinib directly inhibits that specific enzyme, shutting down the cancer's growth signal. The catch: it's metabolized heavily by liver enzymes, the cytochrome P450 system, leading to a lot of potential drug interactions. Needs careful pharmacy review.
Okay. And then briefly, the hormonal and radiopharmaceutical agents. What's the thinking behind using hormones?
It's pretty straightforward. Certain cancers, particularly breast and prostate cancers, are fueled by sex hormones, estrogen, and testosterone. So the therapy involves either blocking the hormone's receptor on the cancer cell or using hormones that have the opposite effect to slow growth.
So for breast cancer, we might see drugs like tamoxifen, which blocks estrogen receptors, or aromatase inhibitors like anastrozole, which reduce estrogen production, like Table 53.4 shows.
Exactly. And the side effects often resemble menopause hot flashes, maybe some fluid retention, edema, mood changes. For prostate cancer, you'd use antiandrogens like bicalutamide or flutamide to block testosterone's effects. Side effects there can include edema, hot flashes, and sometimes gynecomastia.
And there's a really critical point about flutamide specifically for male patients.
Yes, extremely important. Flutamide is teratogenic. It can cause birth defects if a partner becomes pregnant. So male patients must use effective non-hormonal contraception. And these drugs also impact sperm production, so fertility is a vital discussion to have beforehand.
And quickly, radiopharmaceuticals.
These are specialized treatments often handled by nuclear medicine specialists, things like radioactive iodine, I-131, to target thyroid cancer, or samarium-153, used sometimes to relieve pain from bone metastases.
Okay, we've covered a lot of complex drugs and some pretty scary toxicities. Let's bring it back to the bedside. What does all this mean for the clinician? Safety must be paramount.
It absolutely has to be. Implementation starts before you even draw up the drug. Handling requires extreme caution. These drugs are carcinogenic, mutagenic, teratogenic. Anyone administering them needs specific training and certification. And a simple but vital point, always use the full drug name. Never abbreviate, especially with sound-alikes like doxorubicin versus doxorubicin. Errors there can be fatal.
So thinking about prevention checklists, what are the absolute must-dos to avoid the big three catastrophes? Extravasation, nephrotoxicity, and severe myelosuppression.
Okay, checklist. 1, for extravasation prevention, constant vigilance at the IV site. Central lines are strongly preferred for vesicants. Monitor constantly during infusion. 2, for nephrotoxicity, cisplatin and hemorrhagic cystitis, cyclophosphamide. Aggressive IV hydration, that 2,000 to 3,000 ml a day target we mentioned, assuming the patient can tolerate it. 3, a specific equipment check. Avoid aluminum needles or components in IV sets when giving platinum drugs like cisplatin or oxaliplatin, as aluminum can actually degrade the drug.
And the lab monitoring is focused on that myelosuppression, especially watching for infection risk.
Yes, and you have to know about the nadir. That's the point where blood counts, especially white blood cells and neutrophils, hit their absolute lowest after a chemo cycle. It's typically 10 to 28 days after treatment, depending on the drug. Knowing when to expect the nadir lets a team be proactive about infection prevention, especially if the neutrophil count drops below 0.5, that's severe neutropenia.
Beyond blood counts, you mentioned specific baseline checks tied to drug toxicities, like for cisplatin.
Right. If cisplatin is ordered, you need baseline hearing tests and checks of deep tendon reflexes. Why? Because we know it causes ototoxicity and peripheral neuropathy. Similarly, baseline pulmonary function test before busulfan or blomycin, and baseline cardiac ejection fraction before starting anthracyclines. You match the assessment to the known risk.
Finally, red flags. What are those oncological emergencies, like in box 53.3, that need immediate, urgent attention?
Any sign of infection or uncontrolled bleeding is top priority. So a fever over 38.1 Celsius is significant chills, new sores or white patches in the mouth, bleeding gums, a persistent new cough, shortness of breath, or any blood in the urine or stool. These aren't wait-and-see symptoms. They could signal life-threatening sepsis or hemorrhage and need immediate medical intervention. So to wrap this all up, these powerful drugs, the alkylators, cytotoxic antibiotics, targeted agents, they work by damaging DNA or halting cell reproduction. But because they often hit healthy dividing cells too, your clinical role is all about anticipating and managing those specific organ toxicities. Kidneys for cisplatin, heart for anthracyclines, lungs for blomycin and busulfan. It requires tailored, proactive care.
Let's recap those key safety takeaways one more time. 1. Hydration, 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 especially for cisplatin and cyclophosphamide. 2. Meticulous IV site monitoring, preferably using central access for vesicants to prevent extravasation. And 3. Know your specific extravasation protocols. Is it neutralization and cold for carmustine, or cooling and elevation for doxorubicin? Knowing the difference is crucial. All right, here's a final thought to leave you with. Given the intense toxicity we've discussed, these drugs are designed to kill cells. After all, how do we, as a healthcare team, constantly navigate that ethical tightrope? How do we balance maximizing the destruction of cancer cells while doing everything possible to minimize the collateral damage to the patient's healthy tissues? It's a constant challenge in oncology care. A warm thank you from the Last Minute Lecture team. We hope this deep dive helps you feel more prepared, whether you're studying or heading into clinical practice.